Thank you very much for that introduction, for that kind introduction. It's indeed a great pleasure to be here, and I would say honor. And thanks to Neuro Foundation, especially to Dr. Natarajan and his team. It indeed has given a lot of pride to see what Natarajan has achieved here, creating an exclusive center for treating all kinds of neurosciences disorders, and which has become a key healthcare center in this part of the country. And even though, we were more than brothers, sometimes when you face adversities together, you get together. So I think that is how we got together during the MCS trainings. So we faced similar adversities. We were having shared miseries, and then we got together. And I think that was the best thing that could have happened, because every adversity comes with an opportunity. For me, I think that those adversities came with gaining someone who is closer to me than a brother. So thank you, Nataraj, for this opportunity, and congratulations once again on what you have achieved. It's truly remarkable. Now, despite us being close to Dr. Natarajan, has got nothing to do with the AIIMS Neuro Foundation MOU. That has been strictly given on the basis of merit. So we submitted this MOU several months in advance. It was evaluated by the Dean's Committee for several months. And finally, they agreed that, yes, we should go ahead and have an MOU for several reasons. First and foremost, it was in Tamil Nadu, which was quite a distance away from where AIIMS Delhi is situated, which gives a very good outreach for the objectives we are trying to achieve. Secondly, we are dealing with an institution which is purely concentrated on neurosciences. And this is what we are trying to create, a center of epilepsy. And thirdly, there are no epilepsy dedicated centers around this place. So what AIIMS assessed is to look at areas where having an outreach would have the maximum possible impact, and whether the recipients of this outreach were good enough to take up this MOU. And that is where maybe a little bit of push came from us, where we said definitely it can be done. And that's how we ended up having this MOU. And we really look forward taking this forward. And our objective is, from the department's perspective, from the institution's perspective, from AIIMS Delhi, our objective, we are committed to see that epilepsy surgery here in Neuro Foundation Salem becomes the leading center for whole of South India at least. So that's our objective. And I hope, I think that way we are very lucky that we are close to the managing director and we'll be able to achieve it. So there's a saying that when you go ahead to try to achieve something, and if you're really passionate about it, the planets are going to align, the stars are going to align, and things are going to happen that way. So I feel that, things are aligning in the right positions, so we are able to achieve this, and we look really forward for a lot of exciting things. So my talk is, I was asked to give a very simple talk on epilepsy. That's difficult for me. So I will skip the slides where you think. I'll try to make it as simple as possible, because I know there are a lot of students here. There are a mixed audience. There are also neurologists and some neurosurgeons. And I will skip some of the slides, so kindly bear with me, Dr. Manjari. But from a surgeon's perspective, this is the equation we are looking at. We have to understand that the first drug, if it doesn't treat epilepsy, 50% of the patients are going to become drug resistant. So whatever drug you give, let it be a new drug, old drug, most recent drug, most advanced drug, if it is given optimally in an optimum doses and there is enough patient compliance and the patient doesn't get controlled with, those are the 4 categories which Dr. Manjari showed. If it doesn't respond to the first drug, that is where the first red flag must be alerted, that this person most probably has a drug-resistant epilepsy. And you have to understand that drug-resistant epilepsy is not like antibiotic resistance. It's not like you have to give a ton of drugs for that person to become drug-resistant. It doesn't. I think that way the term drug-resistant is a very wrong term. So neurobiological, constitutionally, that patient has got drug resistance. And 30% of the patients in a cohort of 100 patients will be drug-resistant. And if you add a second drug, about 64% will become seizure-free, which means about 46%, 36% are going to be drug resistant. And that is where, most of your options are over once you have done away with 2 drugs. Because when you go to 3rd drug, less than 5% of the patients are going to respond to this drug. So if you have seen a patient not responding to 2 drugs, nowadays it's too easy for the general practitioners or even the neurologist to go on experimenting with drugs for years together because there are more than 2 dozen drugs, which is an absolutely unworthy exercise because you're not going to achieve anything. That's the time the patient should be referred to a tertiary center like Neuro Foundation or something else which can deal with, complex epilepsies. It's also important to understand that only 11% of the patients who do not respond to the first drug will ever become seizure-free, which means almost 89% of the patients are not going to be seizure-free. And drug-resistant epilepsy is ruthless because there is no cure except surgery. So they have to be worked up for surgery as early as possible. And most of the patients, they say it's only epilepsy, it's not cancer. It's okay, why should we treat? He's having 1 seizure in 6 months. But long-term population statistics have shown that you could have 1 seizure in 6 months, but it will be attached to a cumulative mortality of 0.5% per year, which means if the patient has seizures for 10 years, epilepsy for 10 years, the mortality is going to be 5%. If it is for 20 years, it's going to be 10%. And these figures are not going to change with the frequency and duration of seizures. And epileptic encephalopathy, particularly in children, is a very, very significant thing. So, when parents of children come, they say, why do we need to do surgery? He's having 1 seizure, okay. So we say to them, it's fine. But if you do not do surgery, after 4, 5, 6 years, the way you respond to your child or the way the child responds to you will no longer be there. So your child may not actually recognize you as a parent. So that connection is going to get cut off. And if you don't treat today, tomorrow your networks are going to become much more complex. So Manjari has already told this. So if you see any of these factors in your patients from a surgical perspective, so hippocampal sclerosis, having some kind of a tumor, I'm not talking of malignant tumors, I'm talking of some specific tumors like a DNET, dysembryonic neuroepithelial tumor, or a ganglioglioma. These are the tumors which are very typically associated, or a pilocytic astrocytoma, very typically associated, less with pilocytic, with drug-resistant epilepsy. And if you find them, those patients should be treated very early in the course of disease. Similarly, if you see some kind of a substrate on MRI, again, they should be treated. Is there any pointer which works? Because I think it's okay, no problem. So, what do we do in surgery? So, fundamentally, if you look at brain in terms of it being a very complex electronic circuit board, you have a chip which is faulty. So, you have to somehow, you have billions of neuronal networks. So and this is throwing off all these networks off balance. So one type of surgery, what you can do is you can do a complete resection of this. So it's called as a resective surgery. Or you could disconnect it from the surrounding area. That's called as disconnective surgery. Or a third type of surgery which you can do, it's called as a neuromodulation, where you can put some kind of a neuromodulatory mechanism like a vagal nerve stimulation or a deep brain stimulation, which I would like to convey to the audience here, that is, it's not as effective as resective or disconnective surgery and should never be an option of first choice. Now, if you look at epilepsy surgeries, it's an umbrella term, So it's not that you do one single type of epilepsy surgery. You can have various options. And my apologies for this cluttered slide, but the idea is to show you that it's not a very straightforward decision which you take when you do epilepsy surgery, and that's the reason it has to be developed specifically in a tertiary center. It requires a teamwork, it requires an expertise, it requires learning over a period of time, it requires mentorship, so that you can intelligently select what surgery is going to be or what strategy is going to be best suitable for that patient. And that has to be done on a teamwork. And you can have a host of resective surgeries. Then disconnective surgery means we do disconnections. So the biggest form of disconnection is you could disconnect the entire hemisphere from the opposite side. And then, of course, you have this corpus callosotomy. So if the patient is having, multiple seizures, particularly drop attacks, that is where we do a corpus callosotomy. And then, of course, he could do neuromodulation. It could also be classified as a curative and a seizure-reducing type of surgeries. So curative means where we expect the patient to be totally free from the seizures. And then you again, you could have a host of surgical techniques over there, which we will deal in a short time from now. And seizure-reducing surgeries are typically called in the literature as palliative surgeries. I don't like that word because palliative indicates something which is uncurable for a malignant terminal lesion, which is not the case in case of epilepsy. So in epilepsy, even the cases like corpus callosotomy has given us a lot of satisfaction, especially to the caregivers. So I prefer to use the term seizure-reducing surgeries, where you expect the patient to have around 90% reduction of seizures, which is very, very, significant considering these patients could be having hundreds of seizures a day. Now, brief words about neuromodulation. I won't be speaking much about it, but definitely it's coming up in a big way, and there are multiple targets in the brain. The commonest neuromodulation which is done is a vagal nerve stimulator, where you put a generator over here and it is connected to the vagus nerve here. And the next commonest is a deep brain stimulation, and you could target two nuclei. You could target the anterior nucleus of thalamus or the centromedian nucleus of thalamus. So anterior nucleus you target if the seizures are arising from bifrontal or bitemporal area. Centromedian you target if the seizures are arising from the posterior quadrant. So that's a basic philosophy. Now, most important thing about neuromodulation is, it's too easy to convince a patient to undergo neuromodulation, unfortunately, because the doctor will tell him, we will put a pacemaker, it is like a cardiac pacemaker, and it is, and we see that it has a scope for maximum misutilization. So we prefer to do neuromodulation only after each and every option has been exhausted, and that is how it should be. And the reason is because only 50% of the patients in whom it is performed will ever become seizure-free. So the response rate is only 50%. And but the good part is, this seizure freedom can increase over a period of time. So your outcomes at 10 years will be much more better than it was at 5 years, and the outcome at 15 years will be much more better at 10 years. So there is gradual improvement of but that's very marginal. And of course, for devices like vagal nerve stimulation, we give them a wristband with a magnet. So whenever the child has an acute burst of seizures, he could just apply the magnet and there will be a burst of activity and it could control the seizures there and then. So there are definitely advantages of VNS, but again, this should be used, in a very pragmatic manner. One should not, we have seen, VNS being put in cases of patients who have hippocampal sclerosis. So they came to us, we had to do surgery and then. So these are the things. That is the reason, even though it is it's not a very difficult surgery to do, but the workup is important. So whenever I hear about neuromodulation, I always am reminded of this joke to make this, talk less serious. There was a very big oil rig in Saudi. It's a joke. And it used to generate tons and tons of oil every day. And one day, suddenly the oil stops coming. And they're losing, millions of dollars every day. So they call this expert who comes, usually it's from US, because US are people, Americans are portrayed as saviors of this world. So he comes from US. And then he spends almost 10 days making notes, and they're getting restless because he's been flown in by a chartered flight, and he's being put in a hotel, he's being given all the expenses, and and then after 10 days he says, okay, now I know the problem. He takes a hammer and he goes to one part of the oil rig and hammers it very hard, and suddenly the whole oil rig opens up. Oil starts flowing again. So then he says, okay, my fees is about $1 million. So the company is astounded. They say, okay, can you give me a breakup? So they say that it's $1 to hit with the hammer and rest of the money to know where to hit it. Okay. So that way, epilepsy surgery, I won't say it's very simple, it's a very complex surgery, but you should exactly know where to hit it. Because if you don't know that, you're going to end up failures, and that's why, it's very important to develop dedicated centers. So fundamentally, when we do surgery, what do we resect or disconnect. So when we look at connections within the brain, now we understand that there are something called as nodes. So epilepsy is like a network disease. Okay, so you have multiple nodes. We have enough evidence to show that brain is not randomly connected. Okay, because if it would use up almost 40% of the body's metabolism. It doesn't, which goes to show that there is a a lot of intelligence in brain connections. So like I was telling to Nataraj yesterday, for instance, if from here, from Salem, let us say you want to go to Buffalo. So what you would do, you would first go to Chennai, catch a flight maybe to Chicago or New York, and from there take another local flight to Buffalo. So in this case, Chennai and New York or Chicago happens to be nodes. So when there's a transmission of epileptogenic networks in the brain, they first go to nodes. And from the nodes, they spread to other major nodes. So what we are basically resecting or disconnecting are these nodes. So we are either disconnecting them or we are removing these faulty nodes. Now if you look at textbooks, this is the concept on the left side which has been described by Hans Luders, who's from Cleveland Clinic, and it's called as a Luderian concept, which says that you have a lesion in the center, which itself is a dead thing, and surrounding this you have an epileptogenic zone. But now people understand that lesion need not be in the center of the epileptogenic zone. It could be at a distant. So you could have a lesion in the temporal lobe, but the networks could be in the temporo-occipital area. And more important, what you have to understand is these networks are not static. They're dynamic. They're expanding over a period of time. So if you do not treat a patient today, and the patient comes back after 5 years, the networks are going to become much more complex. You will have to again investigate the patient all over again, and the outcomes of surgery are not going to be as good enough. So that's the reason once you identify a surgical substrate, that patient should be subjected to surgery as early as possible. Otherwise, you're losing time, you're losing brain. Now, if you look at the mechanism, the recent mechanism on how these networks are recruited, so you find that there are local neurons with bistability oscillating systems. So sometimes they become epileptogenic, sometimes they're normal. And they keep on oscillating, It's like that novel, I'm forgetting, that guy is, very good looking in the daytime and he becomes a monster in the night. I don't remember that story from Chandamama. So epileptogenic neurons are like that. When they become epileptogenic, they throw seizures and they become totally normal. Now what happens is when they recruit distant neurons, which again reinforce them, and they recruit even more distant neurons. So these networks are expanding over a period of time. Now, do we have any evidence that surgery actually works? From this perspective, there are 3 very important randomized controlled trials. So for students, you should understand that whenever we speak about something, whether it works or not, the class 1 evidence is a randomized controlled trial. We can't have randomized controlled trial for everything. It's impossible. But at least we try to do that. So over here, the most important RCT for epilepsy is one done by Weeb et al., which was published in New England Journal of Medicine. It's a journal with the highest impact factor. It's almost about 100 impact factor. And then they compared a group of patients with hippocampal sclerosis who underwent early surgery versus them undergoing a medical treatment for 1 year. And then they found a difference of 58% good out, complete seizure freedom versus 8% only with medical therapy. And then there was another very important study by Pete Engel from the Engel's textbook of epilepsy, who did an early surgical therapy for drug-resistant epilepsy in temporal lobe. So these are the 2 very important trials. And if you see the numbers needed to treat is the number of the patients you should treat in order to make one patient, in order to cure one patient. And if you see numbers needed to treat with epilepsy surgery is one of the most minimum in neurology. I think only next after a headache. So it's very effective. The third most important RCT is one published by us, again in New England Journal of Medicine, has more than 1,000 citations, which is a randomized controlled trial for pediatric patients with a drug-resistant epilepsy. And it has clearly shown that there is a 10-fold improvement. So what did we do? we have a waiting list for 1.5 years to 2 years. So what we did, I said, let us do a study to see whether it works, because you can't for the sake of study, you cannot bend the ethics. So we said, okay, so one surgical group we will operate immediately within 2 weeks based on randomization, and the non-surgical or medical group we will admit as per the usual waiting list. So they will become the medical group. And we followed up the patients. We saw within 1 year what happened, and we found a 10-fold improvement in children who undergo surgery as compared to those who do not undergo surgery. Not only that, we found that children who undergo surgery after 1 year have irreversible cognitive encephalopathy, which does not recover even after doing surgery. So not only it's important to do surgery in kids, but it's also important to do it as early as possible in order to prevent epileptic encephalopathy. So this trial had a huge implications. We were getting phone calls from all the insurance companies in US. So because in US also, you would think it's a very highly developed country. It's not. If you go and see practices in rural US, you'll find some of the practices even worse than what we have in India. So over there also, kids, they will go on treating, the GPs go on treating, they don't refer it to tertiary center. So after this, the practice changed. So all this, the GPs, they become medically liable if they don't refer a kid with, moment they don't respond to 2 drugs, you have to refer the kid to a tertiary center. Otherwise, they become medically liable. So whom should you refer? So ideally, any patient you have, moment you start a first drug, they do not respond, this is the best time for you to refer the patient to a tertiary center like a Neuro Foundation or any other center which is doing drug-resistant epilepsies. And here it should be worked up as early as possible to look for a substrate for epilepsy surgery, and then they should be operated as early as possible, because epilepsy surgery is not a treatment of last resort. Now, among all the investigations, normally when we start doing an epilepsy surgery program, there is a lot of barriers to it. And you'll find that most of the neurosurgical residents are not taught about epilepsy surgery, they're not taught about anti-seizure medications. Nobody wants to do it. They say it's too much of effort. Most of the neurologists don't want to do epilepsy surgery. They're very comfortable sitting on armchair and going on changing one anti-seizure medication after another anti-seizure medication. So the reason is it requires a teamwork. It requires a lot of work to do. And most important, it requires the neurologist to admit that surgery is actually superior. It's not very easy for all neurologists to do that. With my most profound respects to them, but that is how it is. So this again, I apologize for this busy slide, but what I want to point out is that the first and the major bottleneck is the MRI. So if somebody has a video EEG and MRI with a good expertise, having just this is not enough, you should have a good training expertise, you will be able to tackle almost 60 to 70% of the pathologies. And we are still learning. And MRI particularly, is something which the normal neurosurgeons are not used to. Now, what are normal neurosurgeons used to? They're used to seeing big tumors. So the moment they see on film, it's over. So it's not the same with epilepsy surgery. So those are the categories we go. So in epilepsy surgery, we never see on films. So we have a dedicated room which is called as a epilepsy surgery meeting room or whatever it is. It should have a high definition large monitor, and all the slices of MRI should be directly viewed on this monitor by the entire team. It's not as if the radiologist will see and give a report. It doesn't work like that. You need to have a comprehensive epilepsy surgery meeting once in a week, and you have to sit in that room with the whole team together, and you have to visualize the MRI slice by slice on the high definition monitor. You should never see it on the films. And then we found that over a period of time, this of course is a harness protocol, how it is done, and I won't go into the details of it. So we have found at AIIMS that approximately 60% of our patients, they come with multiple MRIs. And in 40% of the patients, when we do a proper epilepsy protocol MRI, we are able to pick up a substrates. The reason is most of the substrates are subtle. They're like cortical dysplasia. Even hippocampal sclerosis, most of the neurosurgeons cannot pick up. That's said to be the grossest form of substrate in epilepsy surgery. So these are the substrates which you need to pick up, because if you pick up, let us say, you see this. This is called as a transmantle sign. So moment you see a transmantle sign, it means it's a cortical dysplasia type 2B. And if you do surgery, this patient is going to be seizure-free. So the first job of an epilepsy surgery team is to convert so-called negative MRI into a positive MRI. And that is the biggest bottleneck. Why? Because most of the neurologists will do an MRI, it's done on film, nothing here, no, continue it. So that thing should be stopped, No, so that is the reason, even if the MRI is negative, so-called negative, it has to be referred to a tertiary center, because these centers have an expertise to convert a negative MRI into a positive MRI, which could change the equation for the patient. In about 20% of the cases, we have a strategy called as coming back. Now, there's a very nice paper here, which is called as a Sutton's law in epilepsy. Now, Sutton, I was telling to Nataraj, he was a gentleman bank robber. You can read about him in Wikipedia. He used to rob only banks. He would never rob any individual, never any houses. He used to take even unloaded guns. He would not have bullets in those guns, because he was afraid that by accident it could go off and it could harm somebody. And ultimately he was caught, and he is said to be one of the biggest robbers of the century, because he robbed so many banks. He became an expert of, a center of excellence for robbing banks. That is what he became. Then finally when he was caught, he said, you have robbed so many banks. Why did you rob banks? Why didn't you rob houses? Why didn't you rob? So he gave a statement which is very simple but very profound. He said, that is where the money is. So this statement translated not only for medicine but also even for cost computing and in bank management. Why in medicine? Because in medicine it adds to the rule that always think of something which is common. Don't think of something very uncommon. So that's what it translated into. In cost computing, it translated into the fact that always keep your expenses which you think will be most commonly done. Okay. So in 20% of the cases, we have something called as coming back. So we do a more advanced investigation. We find something abnormal. For instance, here the MRI was normal. We did a PET MRI fusion. We found this large area of hypometabolism. We went back, and then we could find out this subtle cortical dysplasia. So this training of coming back and identifying the substrate on MRI never ends. It's a lifelong learning experience. We are learning. Our radiologists are learning. That is why the radiologists have to sit with you. Now, if you see this patient, he underwent 12 MRIs, all were reported normal. The Manjari kept on saying, there's something in the frontals, and the radiologists got fed up. They got angry. They said, I'm not seeing any MRIs. He got up and left the room. Okay. Then finally, we put in a stereo electroencephalography. And then we found that all the seizures were actually coming from the right basifrontal area. Okay, then we asked the radiologist again, I think there is something abnormal. He says, nothing, there is nothing. So we did surgery. That came as histopathologically positive for type 1 cortical dysplasia. We went with the report. See, there is something. Then he said, okay, I think there is something. So there is a learning of coming back. Okay. And now we are even more sensitive. Now, today, if we see this such MRI, we can pick up this. You see this? It's a very subtle loss of gray and white matter interface. But now, if you see this, immediately we become, the radiologist also is very, very sensitive. So this learning never stops. That is why you need to have dedicated centers doing this. You can't do this once in a month, once in 2 months. That doesn't work out here. You'll be missing out a lot of patients. Now, we have never done a WADA's test. We have always been doing fMRI, and this can be something very easily developed. If you have an MRI, you can easily develop your own memory and language protocols for WADA. So that is the major bottleneck. That takes care of 60 to 70%. So whenever we talk, people think that, oh, you need to have everything, only then you can start epilepsy. It doesn't work like that. You have a dedicated MRI, you have a video EEG, you have expertise, you can pick up 70% of your substrates. Only in 30% of substrates, you need to go in for more advanced investigations. So we have a MEG, because it's a tertiary center. We have done more than 3,000 cases now, but you have a good access to NIMHANS Bangalore, so you could easily get a MEG done from there. And these are some of our papers we published from MEG. Then you could also do multimodal imaging. So that's an upcoming thing. So where you put various imaging structures on various. Why is it like that? So, epilepsy is not a static event. You look at a tumor, it's like a mountain. It will always stay. So anybody comes in the night, anybody comes in the morning, you just take a photograph, it's there. Epilepsy is not like that. It's like a Hindu marriage. So many, for 3-4 days it's going on, and every event is different. So if somebody comes with only one photograph, he will not have an idea of the whole marriage. So you need at least 30-40 photographs to understand what is happening. Then you know that's how epilepsy is a dynamic evolving event. So now each of this investigation has got a certain representation in space and time, and they're different. So MEG has got a higher representation in space, but not in time, but not so much in space. PET has got again higher representation in time. So that is why when you don't get the substrate easily, you need to fuse multiple images so that you can get an idea of something called as concordance. So in epilepsy surgery, we speak about concordance. We say whether the investigations are matching with each other. So you put multiple images, you get something called as a vantage point. I don't know how many of you have seen this movie. It's a thriller movie. But I liked it because it kind of showed me a concept of how in my workup for epilepsy surgery happens. So it shows, a terrorist activity, but it shows a perspective from different points of view. And they are very, very different. Only when you join all the events together, that is where you are able to understand it completely. But if you look at it from one particular point or one particular perspective, you're not able to understand how the event is happening. Now, the workhorse for any epilepsy surgery program is electrocardiography. Now, we have done more than 2,000 of this. So that was the caution, when we started doing ECOG more than 25 years ago, we had a lot of negative feedback from all the major centers across the world, especially from the US. They will say, ECOG doesn't, it's useless, don't want. But then we did something. First of all, we streamlined the pre-anesthetic techniques. So we said that this is what should be the anesthesia protocol. Then we adopted this grading system from Gary Mathern. He's a mentor under whom I trained in UCLA. Because one good thing about UCLA is they would use electrocardiography extensively. And we created a grading system. So when the neurologist says grade 1 or grade 2, we are able to understand. Rather than the neurologist saying, what do you see? I still see some spikes here. The better background is slightly better. Neurosurgeon doesn't understand anything like that. Whereas you say, madam, is it earlier, pre-op, it was grade 4. What is the grade now? I've resected. They'll say grade 2. Okay. So that's a common language. So this is a grading system. 1, 2, 3, 4, 5. So 5 is most abnormal and 1 is close to normal. But what you have to understand is a perspective. You cannot eliminate the spikes completely. Okay, because the brain has been firing for so many years, you can't expect the fire to be extinguished immediately. It will take a couple of months or so. You have to see by what. Let us say it was grade 5 pre-op. So when you do post-op, let us say it's become grade 2. It's a very good. So that's where you can't go on chasing the entire spikes. So these are some of our papers in electrocardiography. So you can see in one patient, score 5. So we did multiple resections with multiple ECOGs. And those blue lines show the extent of resections. So initially it was score 2, and then it became score 1 finally, which was normal. So we were quite satisfied with the resection. You see this. This is called as a transmantle sign. So moment you see a transmantle sign, it means it's a cortical dysplasia type 2B. And if you do surgery, this patient is going to be seizure-free. So the first job of an epilepsy surgery team is to convert so-called negative MRI into a positive MRI. And that is the biggest bottleneck. Why? Because most of the neurologists will do an MRI, it's done on film, nothing here, continue it. So that thing should be stopped, So that is the reason, even if the MRI is negative, so-called negative, it has to be referred to a tertiary center because these centers have an expertise to convert a negative MRI into a positive MRI, which could change the equation for the patient. In about 20% of the cases, we have a strategy called as coming back. Now, there's a very nice paper here, which is called as a Sutton's law in epilepsy. Now, Sutton I was telling to Nataraj, he was a gentleman bank robber. You can read about him in Wikipedia. He used to rob only banks. He would never rob any individual, never any houses. He used to take even unloaded guns. He would not have bullets in those guns because he was afraid that by accident it could go off and it could harm somebody. And ultimately he was caught, and he is said to be one of the biggest robbers of the century because he robbed so many banks. He became an expert of, a center of excellence for robbing banks. That is what he became. Then finally when he was caught, he said, you have robbed so many banks. Why did you rob banks? Why didn't you rob houses? Why didn't you rob? So he gave a statement which is became seizure free. So this was about 15 years ago, but now there is enough evidence coming out. For instance, you see this paper in cerebral cortex where they have shown that even though we imagine hippocampal sclerosis to be a focal disease, but there is a diffuse thinning of gray matter in entire brain. So even though it's a focal disease, there are diffuse implications. And these account for the 30-40% of failures which can happen in these surgeries. But you have to understand, these patients would have never responded to drugs. But they have, with surgery, they've got a good response. And this is a paper we published. I was telling Nataraj yesterday. So what our research scientists have done is they have done intra-cellular electrophysiology. So we research the brain, we give it to them. They put it in artificial CSF, and under phase contrast microscope, they introduce electrodes into individual neurons, and they record potentials from that. And from that, they found that most of the activity was actually coming from anterior temporal lobe. So with this, we revised our surgical technique. We don't remove the entire temporal lobe. We just do a polectomy, because we know that is where the maximum papillotogenic networks are concentrated to. And this is a very good meta-analysis which has been published in Neurology by Josephson, which clearly shows, based on all the studies which have been published, that an anterior temporal lobectomy with amygdalohippocampeectomy is much more effective than a selective resection. Now, people may ask a question that if I remove more brain, will you have more memory loss? It doesn't happen. There are studies which have clearly shown that people with a larger resection have a better memory and language outcomes. And what is the reason? Because whatever you are removing are completely abnormal. They are all abnormal networks, and if you leave them, the only thing they are going to do is produce seizures. So again, you can see that the best outcomes are only for an anterior temporal lobectomy and amygdalohippocampeectomies. Now, it's very important to find a lesion, because moment you find the lesion, you find that your outcomes in epilepsy surgery, they increase dramatically. And so that's why we keep on searching for a lesion. We try to find a lesion. That's the first bottleneck. Now, this is a very recent paper which has been published. So does it mean that if there is no lesion, we cannot do surgery? No. 30 to 40% of the patients what we treat today at AIIMS do not have any lesion on MRI despite doing an epilepsy protocol. They are totally MRI negative. But their outcomes are around 40%, maximum 50%. So you can see in the study, the outcome again here was around 40%. And 5-year outcome was around 30%. So it's not as good. Now in MRI negative, temporal lobe resections again have a much better outcome. But parietal lobe outcomes have lesser outcomes. Now in this subset of patients, they found that even histopathology was negative. Okay. So this is very important, because when we resect so-called large brain, which is totally MRI negative, we give it to the pathology. The pathology will say it's totally normal. And then the surgeon is worried, because he is worried that the patient can sue him. More recent, even in our series, we found that about 20% of them were histopathologically normal. And the patient's relatives come back, worried, histopathology is normal, what have you removed? You removed normal brain. It's not that. We have removed abnormal networks which cannot be discerned on histopathology, standard histopathology. But the proof of the pudding is that these patients, they become seizure-free because we have removed abnormal networks. So I will skip some of the slides, and I'll show you an example of an MRI negative temporal lobe epilepsy. So this is a 28-year-old female, seizures for 13 years, MRI totally normal, PET totally normal. Ictal SPECT showed a focus in the left basitemporal area, which also corresponded with the MEG. So we have two advanced investigations corresponding with each other. So what we did is we put electrodes. We put the stereoelectroencephalographic electrodes. So we had a hypothesis. We did think that it was coming from the left temporal. So we always go ahead with hypothesis. So we put electrodes. And with that, we were able to localize it to the left temporal, anterior temporal lobe, not coming from hippocampus. So that's the exposure during surgery. We did an electrocorticography. It was grade 5. Then we resected the lateral temporal lobe, but we left the amygdala intact. And we did an ECOG again, which was grade 2, grade 3. It's not normal, but definitely it's improved. And then when we resected the amygdala, it became grade 1. So even though the hippocampus was preserved, we resected just the amygdala, it became grade normalized. So we did not have to resect hippocampus in a dominant temporal lobe. So using stereoelectroencephalography, we were able to operate on a completely MRI negative patient where we did resections. And so now regarding the extent of resection of hippocampus, again, this is an answer to my surgical colleagues. So Wieser, who was a neurologist to Yasser Gill, he published this. He said you have to go right up to the superior colliculus. But is that really required? Means you have to go right up to the tail of hippocampus. Now, there has been a recent publication which said that there is not much of difference whether you go to the tail or you resect up to the hippocampus. Again, there are, some slides are missing. But again, there are some recent papers to show that there is a greater memory loss if you resect hippocampus on the left side, up to the tail. So the current ideology we follow is that if it is a left-sided lesion, we assess the patient. If the patient is having a lot of seizures, we resect up to the tail. If the patient is having infrequent seizures and the memory is preserved, we resect only 50% of the hippocampus on the left side. But the right side, we always make it a point to go up to the tail of the hippocampus. Now, more recently, in the past 6 months, the role of pyriform cortex has come up. How many of you have heard of pyriform cortex? How many of you have not heard of pyriform cortex? So I've been doing these surgeries for 25 years. I've not heard of pyriform cortex. So I read up the anatomy. So it's a very small cortex which is present at the junction of the frontal and temporal lobe. And it's coming up in the recent papers as being one of the significant areas. So you need to excise this if the patient has to become seizure-free. Because when you excise it, the outcomes definitely become better. So surgeons now have to read about pyriform cortex and ensure that that is excised whenever they are doing a temporal lobe surgery. Now, one of the issues is how can you reduce the memory loss whenever you operate hippocampal doing a temporal lobe surgery. So on the left side, if we reduce the hippocampal resection to about 50%, we can reduce the memory loss by about from 40% to about 10%. So if you want to preserve memory, especially on the left side, you can go up to 50%. The outcomes still are going to be quite okay. Another technique which has been devised by Dr. Kensuke is a very good friend of mine. So both of us currently are chairing the Asiano-Oceanic Epilepsy Committee, which is a part of International League Against Epilepsy. So he described the technique of hippocampal transections. So you could do multiple transections on hippocampus. So that again will preserve memory while reducing the seizures. So this is the current ideology which we follow. I would always prefer to resect hippocampus right up to the tail, as we have demonstrated yesterday. But if they became seizure-free. So this was about 15 years ago, but now there is enough evidence coming out. For instance, you see this paper in cerebral cortex, where they have shown that even though we imagine hippocampal sclerosis to be a focal disease, but there is a diffuse thinning of gray matter in the entire brain. So even though it's a focal disease, there are diffuse implications. And these account for the 30-40% of failures which can happen in these surgeries. But you have to understand, these patients would have never responded to drugs. But they have, with surgery, they have got a good response. And this is a paper we published. I was telling Nataraj yesterday. So what our research scientists have done is they have done intra-cellular electrophysiology. So we research the brain, we give it to them. They put it in artificial CSF, and under phase contrast microscope, they introduce electrodes into individual neurons. And they record potentials from that. And from that, they found that most of the activity was actually coming from anterior temporal lobe. So with this, we revised our surgical technique. We don't remove the entire temporal lobe. We just do a polectomy, because we know that is where the maximum papillotogenic networks are concentrated to. And this is a very good meta-analysis which has been published in Neurology by Josephson, which clearly shows, based on all the studies which have been published, that an anterior temporal lobectomy with amygdalohippocampeectomy is much more effective than a selective resection. Now, people may ask a question that if I remove more brain, will you have more memory loss? It doesn't happen. There are studies which have clearly shown that people with a larger resection have a better memory and language outcomes. And what is the reason? Because whatever you are removing are completely abnormal. They are all abnormal networks, and if you leave them, the only thing they are going to do is produce seizures. So again, you can see that the best outcomes are only for an anterior temporal lobectomy and amygdalohippocampeectomies. Now, it's very important to find a lesion, because moment you find the lesion, you find that your outcomes in epilepsy surgery, they increase dramatically. And so that's why we keep on searching for a lesion. We try to find a lesion. That's the first bottleneck. Now, this is a very recent paper which has been published. So does it mean that if there is no lesion, we cannot do surgery? No. 30 to 40% of the patients what we treat today are reservations. But personally, I'm not too much convinced about limited resections, because I always want the patient to be seizure-free. That is what the caregivers are more worried about. Now, in temporal place is something we should not miss out whenever we are evaluating these patients. Now, we have done some surgical strategies for the first time in the literature. So we have moved to more minimally invasive techniques. So rather than doing large resections, we do disconnections. So that is a TPOD. So we disconnect the posterior quadrant. So we do a cut so that the posterior part of the brain is now disconnected from the ventral part of the brain. So this is a patient, 19-year-old male, presenting with seizures from the posterior quadrant. And you can see, rather than doing a resection of the occipital lobe, we have done a disconnection here, so that the occipital lobe and the temporal lobe is now disconnected. So this is called as a temporoparieto-occipital disconnection. Now we brought in both endoscopes and radiofrequency ablations into epilepsy for the first time. So we described techniques of endoscopic corpus callosotomy, endoscopic hemispherotomy, and those are the papers. And we also described radiofrequency ablations for hypothalamic hematomas and doing a hemispheric disconnection. So this 5:47, how much time do I have? Should I stop now? So I will stop here now, because again, these are all technical stuff which is going forward. So I won't like to show it anymore here, because it's something which mostly neurosurgeons would understand. So I will end. Let me go to the last slide. So imaging, one has to extract as much as possible from the MRI, for which we need to develop the expertise. So one has to develop a dedicated room for these discussions with a high definition monitor. One has to look at films. One has to do a proper protocol for harness protocol. And it's a constant learning. You have to do advance, you have to come back. And as the team goes on looking at it over hundreds and hundreds of MRI, they'll start picking up. And we from All India Institute, we will mentor the centers so that they will also become experts in picking up these substrates. Electrocardiography is a very, very useful adjunct, which again, Neuro Foundation is using it. I'm very happy to note. And using the grading system, using the proper protocols, one can localize networks to a very good extent. And we have introduced minimally invasive techniques, particularly radiofrequency ablations for hypothalamic hematoma as well as for hemispherotomy. And now that Neuro Foundation has got a very good stereotactic frame, the next case they have, particularly hypothalamic hematoma, we could easily go ahead and do a radiofrequency ablation. Now, in terms of temporal lobe, I have already told you what are the conclusions. And of course, I had some slides about stereoelectroencephalography with radiofrequency thermocoagulation, which I have not shown here due to shortage of my time. But that is a very latest technique where in MRI negative, you put multiple electrodes and you're localizing the networks rather than the lesions. And based on this, you're doing, so what we do is we burn the electrodes rather than doing an open surgery. And if the patient is still not seizure free, then we do an open surgery. So with this, I will end the talk. So definitely, surgery is a little bit more complex. I was in two minds. Should I keep it really ultra simple so that most of you can understand? But then I thought, let me go through it and see how it picks up. So I wanted to show the basics as well as a little bit of advanced stuff so that everybody could get an idea of what exactly is happening in the world of epilepsy surgery. So thank you once again for this opportunity, and I wish the team at Neuro Foundation all the best. And we look forward having a very long time associated collaboration with them. Thank you.
Thank
As a pediatrician, we used to see a lot of gliosis secondary to insult in the newborn period or infancy. They are presenting with the refractory seizures. For gliosis, is there any surgical options?
So that's a very good question. Hypoxia is maximally occurring. And these patients often present with the drug-resistant epilepsy. Now we discuss these cases, try to discuss this with some of the colleagues from outside. And they had no experience. So this is something very unique to our country. So we did a complete workup, Dr. Manjari did a complete workup, and most of the cases, I would like her to also comment, we found that the localization was from one side. So these patients, they were subjected to a technique called as temporoparieto-occipital disconnection. So what we did is we disconnected so that the posterior quadrant, which includes the occipital, temporal, as well as a part of a parietal lobe, is now totally disconnected away from rest of the brain. It's a minimally invasive technique. And with this, we were able to achieve about almost 60% of seizure freedom in these patients. And we have published this paper also. That was a new thing what we found, that in gliosis, usually it's unilateral, it's not bilateral. So these patients definitely should be referred for a workup in a comprehensive epilepsy surgery center. Manjari, you want?
So this is very common. In fact, majority of drug-resistant epilepsy patients are those where there is hypoxic damage, and the hypoxic damage is usually bilateral. So very often you will see these children have low intellect, and they are mentally retarded, they have behavioral issues, and they also have seizures. If we can prove that 80% or more of the seizures are coming from one side, preferably that happens to be the non-dominant side, then we can consider, and the seizure types could be focal, or they could be drop attacks, or they could be, secondary Lennox-Gastaut type syndrome also. But if you can prove by all the tests that seizures are coming from one particular quadrant, either right or left, then that can be disconnected, provided you document enough seizures. So usually these children have very frequent seizures also. In one day, they will have 10 seizures in the monitoring unit. So in those 10, if 8 are coming, say, from the right side, then you can counsel them, see both sides are abnormal. However, 80% whatever we documented is coming from right, and hence maybe we can do a disconnection. That is one option. But if they come very early, if they come before they are 10 years old, and their seizures are coming from both hemispheres, like 40-50% both sides, or they are generalized, like drop attacks with generalized Lennox-Gastaut-like picture, then you can offer corpus callosotomy. At least their falls will stop. So corpus callosotomy is option for those with bilateral damage, seizures coming from both sides, or Lennox-Gastaut generalized seizures. Callosotomy is a good option. Suppose the patient is having seizures which are coming from both sides, and they are above 10-12 years, where you don't want to see the effects of disconnection of the corpus callosum, then you can plan VNS. VNS is expensive. It is not curative. It is palliative in the sense it will reduce the number of seizures, but it will not make them seizure-free. And the battery has a limited life. So the cost of VNS, the cheapest model is around 6.5 lakhs. The most expensive model is 12 lakhs. So that is expensive. That is the last option. If you can't offer surgery, they don't want surgery, they can't afford surgery, then you can still try diet. Because with diet also there is a reduction of seizures. So you have to put them on modified Atkins diet with very low carbs, or you have to put them on ketogenic diet. That also helps. Otherwise, they have a very bad prognosis as it is. So, but you have to counsel them. You should first ask them their expectation. What is your expectation? If they say my child will become fully mentally normal, will start becoming Ramanujam in maths and all, you tell them that is not going to be met. The intellect will not improve. We can only help in reducing the falls and the number of seizures. We cannot cure the intellect. So those things have to be counseled beforehand only.
Thank you.